Dr. Torres is back to teach. I can't help myself. Even if I'm not affiliated with anybody, I will always be a teacher now until I die. Some important lessons to be thought about. If someone is coming with cardiac arrest, everyone wants a definitive airway, an intubation. But I tell people, yo, the guy has no pulse and he's dead, he's not moving, why not throw in something called a supraglottic airway, King LT, a device that looks like this, or size appropriate, or something like this. And the reason I tell you is the guy has no pulse. Put something like lubed up, put in correctly, right? Put it in, and make sure you have end tidal to prove to everyone in there that this is working, right? I put a ring on it. That was the technique I just quickly did. Distracted the jaw by grabbing the tip of the tongue, right? Tip of the tongue. Grab the angle of the tip of the tip of the jaw along with the tip of the tongue. Distract anteriorly and push down that quickly placed the supraglottic airway and put end tidal to confirm that you're truly ventilating with supplemental oxygen, right? And then you think, oh, it's just aerating air in the belly. No. I'm gonna show you something. You can't do this right with our patients, but look, chest wall rise. And if you don't believe me then, patient has balloons for lungs. So some people act like supraglottic airways or a cop-out. Get me his pulse back. Get him Ross, return to spontaneous circulation. And then show me your intubation skills after you get him back. Do the Lazarus thing. Bring him back from the dead. Either you're Jesus or your skills are just mad wicked or mad lucky that day. But get the patient Ross and then you intubate them. If you're short-handed and you're the one running the code and you need to put an IO in or a central line in and give orders to give medications and control the airway, this is a convenient way of doing it. Now, if you tell me people say it doesn't work, you put the wrong size in or you inserted it too deep or too shallow. You didn't adjust to the waveform. You understand that? Adjust to the waveform to confirm if it's in correctly, right? And back correctly, right? Usually every 5 seconds. Right? He just needs 12 breaths per minute, maybe every 6 seconds if you wanted to. Right, for 10 breaths a minute. Give him some oxygen while he's in cardiac arrest. Tell respiratory to back gently. Be careful. Don't kill the patient. But this is something to be thought of when you have a cardiac arrest. And you're by yourself. Not a team of people. Not a code arrest team. Rapid response coming down from the sky, from the heavens. You work overnight at a remote access location. You are the airway guy. You are the resuscitationist. Learn to be self-sufficient and do enough for the patient to keep them alive. Not inferior care, you're providing oxygenation. Don't futz around trying to intubate someone who's a difficult airway, spending too much time and wasting too much time focusing on one part of the thing, a part of his resuscitation when he has no pulse, or maybe he has a shock or rhythm issue, shocking more often and finding the antidote to why he's dying. And doing a quick, fast, and that 10-second pause. You understand? You have enough issues going on instead of just focusing on airway. You're not just the airway guy. You're more than that. You're a resuscitationist. So again, start using your supraglottics way more often. During cardiac arrest is definite. You can actually use them in traumatic arrest. They'll tell you that's not definitive. Hey, there's no contraindication. Prove to me that you get the pulse back. Then replace it with a definitive airway with either a surgical airway or an oral intubation. When you get the pulse back. Impress me that way. And then you try to impress me with your skills in airway then.